respected chairpersons, and distinguished delegates, speakers, good afternoon. At the outset, let me thank the organizers for giving me the opportunity to talk in front of the August gathering. My talk has been modified. I'm supposed to talk on carotid angioplasty and stenting only. And I'm going to mainly highlight on the techniques and some examples where difficult angio architecture has been negotiated various the hardware, and we have produced good results in fair number of patients. So what are the hardware that we use? Generally, we use a long carotid sheath. There are several of them from the different vendors now. The most commonly used is the carotid sheath, 90 centimeter, 6 French, which gives the inner ID of 086, which is the, I think, very sufficient inner ID. But there are other availables also, which, of course, based on the operator's preferences, the individual operator will prefer the guiding catheter. Then we have some guide wires. Most of the time, it is the rapid exchange system which is being used now. So we prefer 014 wire. There is one stent which is compatible with both 014 and 018, that is Zilver from Cook. But apart from this, there are very good wires now for microvention. The Traxxas one is a very good micro guide wire. Then Expedion, and of course, there are several others, stabilizers from Cordis and the other guide wires. Then different types of stents, there are several of them. And based on the technology, based on the metal use, you can choose any one of them. Of course, I started off my work with carotid wall stent, which is a closed cell design made of stainless steel and alloy. But now we have nitinol stents as well. So there was a trend in recent time to use open cell design. But now the trend is changing. People are trying to prefer the closed cell design. The stents from EV3 is Protigi, Rapid Exchange, RX. Then this Medtronic has a Cristello, which is in fact a hybrid stent, where in the middle you have a closed cell, at the periphery, the distal, and the proximal end, you have the open cell design. This is just to enhance the flexibility of the stent. Then we have Abbott, which has come with the Exact. We have Aquilink from the same company. And the latest one in the market is Adapt from Boston. It's like a sleeve. So one size is suitable to all size diameters of the carotid. So one size, you can use it because it has a sleeve-like design. Cordis, we have Precise Pro. It's a very good stent, nitinol-based, open cell design. It's compatible with 014 wire. And the carotid sheath and everything else is compatible with it. Then we have balloons, several of them. Most of them are from coronary side, and we use 3 millimeter to 5 millimeter most often. So for pre-dilatation, if the lesion is very tight, I use 3 millimeter balloon. Sometimes 4 millimeter balloon can also be used. And post-stent dilatation is required only if the residual stenosis is greater than 20% stenosis. So I prefer to post-dilate only when the alignment is not appropriate, means the stent is not opposing the arterial wall, or there are some constrictions in the stent at several levels, or if the residual stenosis is more than 20%. So that's the time when I use post-dilate. Patient selection is very important. These were the indications which were published in the past, particularly when the NASCET and ECST trial was going on. So only those patients who are not suitable for surgical recanalization were being sent to the carotid stenting group. And these were the indications highlighted then. So like high lesion, low lesion, if there is significant medical disease like unstable angina, if the patient is symptomatic, severe stenosis, radiation-induced stenosis after surgery, and if the patient refuses to undergo CEA. So that's the time when the patients were being sent for endovascular therapy. And stenosis because of several other causes. And of course, there is a contralateral carotid occlusion. This was one of the major indications for endovascular therapy. Relative contraindication, like patient is asymptomatic, means the stenosis is less than 50%. But now the trend is changing. Even if the stenosis is 50%, if you document that this is heterogeneous, unstable by doing high resolution MR imaging, then you can still do treatment in this group of patients, but only in those patients where you clearly document the heterogeneity of the plaque. Then there are absolute contraindications, like if you cannot safely access the artery, the target artery, and if there are some bleeding disorders like the patient where there is contraindication to heparin, ticlopidine, or clopidogrel. So these are the absolute contraindication for treating the patient by endovascular route. Guidelines, of course, we have guidelines based on the NACET, ECST, and ACAS trial. So anything which is creating complications less than 6% in symptomatic patients and less than 3% asymptomatic patients should be the goal for treating the patient with endovascularism. And the long-term goal is, of course, stroke prevention, but at the same time ensuring that the stenting is a durable technique. Pre-stenting workup, of course, the first thing is a clinical examination, the hematological workup, biochemistry workup. We do CT MRI to look for the brain damage, whether there is an infarct, major infarct, small infarct, acute infarct, or a chronic infarct. That's the reason why we do MR brain. Then MRA and color Doppler, these are two non-invasive vascular imaging tools which will give you the percentage of stenosis, will characterize the plaque, most of the situation, will also tell you the load of the calcium in the stenotic lesion. And this is the way we measure the stenosis based on the NACET trial. We take the artery which is distal to the stenotic area. We measure the B dimension here and the stenotic area. In ECST trial, what we do, we try to draw the outline, the approximate outline of the normal artery and measure the diameter there. And this is the formula which gives you the percentage stenosis. Technique, one patient, 65 years old, with complaint of contralateral hemiparesis. This is the MR diffusion and ADC, which shows infarct on the left side, mainly in the watershed distribution. I think this point is not working. Anyway, so this is the artery which shows a very tight stenosis in the proximal ICS segment, and this is the roadmap under which the guidance, we try to first cross this lesion with the wire. The wire should always be under the region of interest, means it should be visible under the roadmap, because that acts as a guidance for the negotiation of the different hardwares being used. So we always pre-dilate if it's a tight lesion like seen here. Here is the balloon dilatation. Then this is post-control angiogram after the balloon dilatation. I think this is further not moving. आगे नहीं जा रहा है. And this is the stand position. I always take a shoot to see whether the position is appropriate or not. So after I'm satisfied that the position is accurate, then I start releasing the stand. And this is the release technique of the stand. You can see that the proximal end, the distal end of the stand is opening. I can skip some of this slide. Okay, this is the angiogram after the stent has been deployed, and we have then post-dilated with the balloon. This is the navigation with the balloon after the stent has been deployed. I think the video is not working here, but anyway. This is the lateral projection. The wire is always kept distal to the stent. This is the final picture. So this is the final picture. You can see that the stent is nicely deployed, the stenosis is gone. And as a matter of principle, we always take the intracerebral run once the stent is deployed. Another example, in a patient who had a lot of comorbidities, peripheral vascular disease, he had coronary artery disease, he had stenosis in the left carotid, which was operated in 1996, but unfortunately that artery got thrombosed and patient had massive infarction. Fortunately for him, there were good collaterals from the other side, and which perfused the brain to the contralateral side, and the patient improved to a non-disabling state. Now he came to us in the year February 2003. So from 1996 to 2003, patient remained asymptomatic, but he became symptomatic again in February 2003. So this was the initial angiogram, which was done in 1996. This was the normal side, right side, the left side, symptomatic side. This side was operated. There were good collaterals from the carotids. This is post-surgical. You can see the stump of the common carotid artery, left side. This was post-surgery thrombosis of the artery. Aortic arch run, you don't see the left carotid. But there is a good collateral through the ACOM into the MC and the contralateral.
You have 30 seconds left.
Okay.
Come on.
So this is the 2000, sorry. This is stenosis of the right carotid. There is good collateral. We deployed the stent and opened it. This is 2007 follow-up. This is follow-up in 2013. So we have close to 10 years follow-up in the artery, which is single and supplying the other hemisphere. This is 83 years old. You can see the stenotic plaque as well as ulceration. And this was the post-treatment run. This is pre and this is post. We always take intracranial runs for this. I'll skip this. So coming to the AIMS experience, we have done close to 310 carotid stents. Our complication rate was only less than 3% minor stroke, and fortunately all of them improved. So we didn't have any major complication except for one patient who had hypoperfusion bleed. So these are the several trials which have shown that carotid stenting is comparable to the surgical group. And fortunately for us, CREST has given us a very good and robust data which is very, very helpful for the stenting arm. So to conclude, stenting is a viable alternative to surgical treatment. However, we need careful attention to the detail during the procedure and judicious use of pre and post dilatation techniques. 3 major trials, SAPPHIRE, SPACE, and CREST, suggest that stenting is as effective as surgery. AIMS results also show that it's also durable because we have close to 10 years follow-up now. There was inexperienced investigators in EVA 3 years and ICS trial, and which in fact damaged the entire data. So we fortunately have a CREST trial which proves that the carotid stenting is as efficacious as the surgical group, and we should, I think, offer stenting as one of the alternative for surgical treatment. With this word, I'll give you I thank you for giving a kind attention to me. Thank you very much.